On February 8th of this year, an NBC News health reporter sat down with a cardiologist named Dr. Samia Mora and asked her a simple question. Is the cholesterol test you get at your yearly physical actually telling you the truth about your heart? Her answer should have been the headline on every morning show in the country. She said LDL cholesterol tells you how much cholesterol is being carried by your LDL particles, but there is another number called apoB that tells you how many of those particles you actually have. Hold on to that line, because by the end of this video, you are going to understand exactly why that distinction might matter more than almost anything else your doctor checks once a year. Here is the contradiction that almost nobody connects to that interview. Around the same time that story ran, a separate study sponsored by the drug maker Regeneron and published in the American Journal of Preventive Cardiology quietly revealed something almost nobody in mainstream health media picked up. Less than 1% of adults in the United States have ever been tested for apoB. Not 1% are found to be high. 1% have simply ever had the test at all. So you have a leading preventive cardiologist at NYU Langone essentially saying this number matters more at the exact same moment population data shows almost nobody is ever given the chance to know their own number. Health outlets ran the safe version of this story. Get your cholesterol checked, eat less saturated fat. Ask your doctor about statins if your numbers are high. That is the satisfying, simple story everyone is being told. And I understand why people believe it, because it is the story we have all been told since we were teenagers. But today, I want to do something almost nobody in mainstream health media is doing. I want to walk you through why the number your doctor circles in red on your lab report might not be the number that is actually killing people. Everyone is asking the wrong question. Mainstream medicine is asking, is your LDL cholesterol high or low? That is the question on every pamphlet in every waiting room in the country. But here's the sharper question, the one this entire video is going to answer for you. It is not how much cholesterol is in your blood. It is how many particles are carrying it around, and how sticky, how small, and how genetically loaded those particles are. I am going to walk you through 3 competing ways doctors and researchers currently think about this. I am going to be fair to every single one of them, and by the end, you will be able to decide for yourself which one actually explains your own risk. Let me name these 3 frameworks for you so you can hold them in your head as we go. The first one I want you to think of as the amount model. This is the mainstream idea, the one your doctor almost certainly uses, and it says what matters is the total mass of cholesterol floating in your blood, measured as LDL. Think of it like weighing a truck. If the truck weighs too much, that is a problem, full stop. The second framework I want you to call the traffic model. This one says the weight of the truck barely matters. What matters is how many trucks are on the road. You could have 10 trucks each carrying a little weight, or 2 trucks each carrying a lot. Same total cargo, completely different amount of traffic on the highway. The third framework, and this one almost nobody outside of specialist cardiology clinics has ever heard of. I want you to call the inherited passenger model. This is lipoprotein a. And unlike the other 2, this passenger was placed in your bloodstream by your genes before you were even born, and almost nothing you eat or do changes it. The amount model is the mainstream one. It is what almost every primary care doctor in America is trained to explain to you. So let us start there. I do not like knocking down a weak version of an argument, so let me give you the strongest possible case for the amount model, the traditional LDL cholesterol approach, because it deserves that. For over 50 years, large population studies have consistently shown that people with higher total LDL cholesterol have more heart attacks and more strokes than people with lower LDL cholesterol. Statin drugs, which lower LDL cholesterol directly, have been shown across dozens of major trials to reduce heart attacks and save lives, and that effect shows up again and again regardless of who studies it or where. That is an enormous, hard-won body of evidence, and it is the entire reason cholesterol screening became a standard part of medicine in the first place. Doctors are not wrong to check it. They are not lying to you. Lowering LDL cholesterol saves lives. That part is not in dispute anywhere in serious cardiology. But here is the sharp question this framework cannot answer for you. If LDL cholesterol is the whole story, why do so many people have heart attacks with completely normal LDL numbers? And why do some people with high LDL numbers live into their 90s with clean arteries? If the amount is the whole answer, that should not happen nearly as often as it does. Something else has to be filling in that gap. This is where the traffic model, the particle count idea built around apoB, starts to earn its place, and I want to walk you through the evidence the way a careful researcher would, one source at a time. Source number 1, the InterHeart study, which looked at more than 29,000 people across 52 countries, found that the ratio of apoB to apoA1 was a stronger predictor of a heart attack than the traditional cholesterol ratios doctors have relied on for decades. Source number 2, the Quebec cardiovascular study, which followed more than 2,000 men over 5 years, found that apoB outperformed LDL cholesterol as a predictor of coronary heart disease. And the gap was largest precisely in men whose LDL looked completely normal on paper. Source number 3, the Treating to New Targets trial, which randomized over 9,000 patients with existing heart disease to different doses of a statin, found something genuinely surprising when researchers dug into the data years later. When they controlled for other factors, apoB independently predicted future heart attacks and strokes, while LDL cholesterol on its own did not hold up in that same statistical model. Source number 4, and this is the one that should stop you in your tracks, is a position paper from the American Association for Clinical Chemistry, which stated plainly that apoB is a more reliable indicator of cardiovascular risk than LDL cholesterol. That is not a wellness influencer saying that. That is the professional body of clinical laboratory scientists in the country responsible for how blood tests are interpreted. Source number 5, a comprehensive 2025 review published in the European Heart Journal by researcher Alan Snyderman and colleagues looked back across decades of research and found that in 9 separate studies comparing the two, all 9 showed apoB outperforming LDL cholesterol as a predictor. 9 for 9. Snyderman, who is a professor of cardiology at McGill University, has argued that if you measure apoB alongside lipoprotein a, you get a clearer picture of someone's heart disease risk than you get from cholesterol numbers, triglycerides, or particle size measurements on their own. Now, let me show you why this actually happens inside your arteries, because once you see the mechanism, the whole thing clicks into place. Every single particle that can cause plaque to build up in your arteries, whether it is LDL or its cousin VLDL, or the genetically loaded lipoprotein a, carries exactly one molecule of apoB on its surface. Exactly one, no matter how big or small the particle is. That means counting apoB is not an estimate. It is a direct head count of every dangerous particle in your blood, all at once. A doctor at Wake Forest named Michael Shapiro has described a standard cholesterol panel as being like counting how many passengers are riding in cars on a highway, while apoB is like counting how many actual cars are on the road. If you are trying to figure out why traffic is backing up, counting passengers misses the point. What matters is how many vehicles are clogging the lanes, not how full each one happens to be. Someone can have a completely normal LDL number and still have a large number of small cholesterol poor particles, meaning a high apoB, and research shows roughly 20% of people with normal LDL cholesterol actually have this hidden pattern of elevated apoB, quietly raising their real risk while their annual blood work looks perfectly fine. So, here is where I want to bring these threads together into one bigger picture, because I do not think the amount model and the traffic model are actually in conflict the way they are usually presented. I think what is really happening is that your total cholesterol number and your particle count are like 2 different instruments measuring the same underlying event from different angles, and doctors have simply been trained, for historical and practical reasons, to rely on the older, cheaper instrument. LDL cholesterol testing became standard decades ago because it was inexpensive and widely available, while apoB testing required lab infrastructure that most clinics simply were not built around. Over time, LDL became the default not necessarily because it was the more accurate measurement, but because it was the one the entire system had already been built to run on. That is not a conspiracy. That is just how institutions calcify around whatever technology got there first. The reason both numbers often move together is that most of the time, more particles do mean more total cholesterol. It is only in that discordant slice of the population, roughly 1 in 5 people, where the two numbers disagree, and it is exactly in that slice where people are being quietly missed. Now, let me zoom all the way out, because this pattern of a cheaper, older test becoming the default, while a more precise but less convenient test sits largely ignored, is not new in medicine. Lipoprotein a was first identified all the way back in 1963 by a Norwegian physician named Kåre Berg. Think about that. We have known this genetic passenger existed for over 60 years, longer than most people watching this video have been alive. And yet population studies show that fewer than 1% of adults have ever had it measured, even though it affects an estimated 1.4 billion people worldwide and is present at elevated levels in roughly 1 in 5 people on the planet. 60 years of knowing, and still almost nobody gets tested. That gap between what science has known and what actually reaches a patient in an exam room is one of the oldest patterns in the history of medicine. And it should make you pause and ask what else sits in that same gap right now. Now I want to be fair and give you the strongest possible case against everything I just told you, because that is only right. A skeptic would say, look, LDL lowering statin trials are some of the most replicated, most rigorously tested interventions in the history of modern medicine, involving hundreds of thousands of patients across decades, and they work, full stop, regardless of whether you are measuring LDL or apoB underneath the hood. A skeptic would say most people do not need a specialty lab test to know they should eat better, move more, and take a statin if their doctor recommends one, and turning this into a hidden secret risks scaring people or sending them chasing expensive tests they cannot easily access. That is a genuinely strong argument, and honestly, for a huge share of the population, the simple advice is still the right advice. But here is what that argument cannot explain. It does not explain why people with textbook normal LDL cholesterol are still having heart attacks in their 50s and 60s. And it does not explain why national guideline bodies, including the European Society of Cardiology and the National Lipid Association, have already begun recommending apoB and lipoprotein a testing specifically because they catch risk that LDL alone misses. If the old model explained everything, those guideline changes would not exist. So here are 3 specific things I want you to watch for over the next few months that will tell you whether this idea is gaining real ground or fading. Watch whether your own doctor's office starts offering apoB testing as a standard option during annual blood work rather than something you have to specifically request. Watch whether more national cardiology guidelines follow the lead of the European groups and formally recommend a one-time lifetime lipoprotein test for every adult. And watch whether insurance coverage for these tests expands, because right now, cost and access are a huge part of why testing rates sit under 1%, and that number moving even slightly would tell you this shift is becoming real medicine rather than a niche conversation among specialists. If you want to go verify any of this yourself, and I genuinely want you to, look up the 2025 review by Alan Snyderman and colleagues in the European Heart Journal on apoB as a predictor of cardiovascular events, and look up the American Heart Association's scientific statement on lipoprotein a as a causal risk factor for cardiovascular disease. Both are public, both are detailed, and both will let you check every claim I just made against the primary source instead of taking my word for it. I want you to disagree with me if you find something I got wrong. Send it to me. I would genuinely rather be corrected than be comfortable. So, think back to that line from Dr. Mora at the start of this video, the one about counting cholesterol versus counting particles. Now that you know what is actually riding inside those particles and how long we have known about the passenger nobody tests for, I want you to ask yourself honestly, is your last cholesterol test actually telling you the truth about your heart, or is it just the story that was cheapest to tell? I'm Dr. Ava. We'll see you in the next one.